last week we've been talking about gram-negative cocci or cocci. Today we are talking about gram-positive ones. So before we'll talk about specific genuses and the mostly common representatives among gram-positive cocci, we have Staphylococcus and Streptococcus. I mean, I guess these two genuses are one of the mostly known all over the world. It doesn't matter, are you a doctor, do you have anything with medicine or not. It is at least these names are very common. If we're not talking about fact, they're causing a lot of infections among general population. So before we'll talk specifically about these two genuses, I would like to highlight some differences between conditionally pathogenic and mandatory pathogenic bacteria. It is very important to make difference between them in order to know how to treat them, in order to know how to prevent them. What is good about conditionally pathogenic bacteria? The good thing about conditionally pathogenic bacteria is the fact, even if all of these bacteria are very common for us, what does it mean? It means we can be carriers of these bacteria. All of these bacteria can be present among us or on ourselves or in our bodies, in different cavities or surfaces. Anyways, not all the time we're sick, right? Very common example, who had ever tonsillitis? Those who are not raising the hand, probably you didn't start listening the lecture yet, right? Or you didn't take out your earphones, or you didn't stop talking to each other or something like that. So basically, all of us, we did have tonsillitis. It is what everybody knows, but not everybody knows. In most of cases, this infection is caused by the only pathogen that is called Streptococcus pyogenes. Even me right now, I'm in the process of recovery from tonsillitis. Okay. So it is really common infection that very hard to find a person who didn't ever have it. Some people even have chronic tonsillitis. In such cases, tonsillectomy or extraction of tonsils is recommended. A little bit less common, but still, who of you had ever sinusitis? Maybe some of you have even chronic sinusitis. So whenever it is a cold period and you refuse to wear or you've forgotten to wear a hat and to cover your forehead, it starts, right? I guess so. So this infection commonly is caused by Staphylococcus aureus. So a lot of people are carriers of Staphylococcus aureus in nasal cavity and Streptococcus pyogenes in oral cavity. But still, even if almost all of us do have these bacteria in our body, in our bodies, during our life, during the entire life, anyways, not all the time we're sick, right? It is because these bacteria are considered to be conditionally pathogenic. And on this topic, some doctors wouldn't agree with me, especially physicians, especially those who are treating patients, wouldn't agree with me. You know why? Because these bacteria are most commonly found in hospitals. These bacteria are most commonly found in hospitals, so they do, and just in framework of infectious processes, just in framework within the disease. So for them it is strictly pathogenic bacteria, because as often they can find it, all the time it is a disease, all the time it is an infection. But basically, and from this point of view, we can agree to each other. But basically, which is the main explanation of conditionally pathogenic, or definition of conditionally pathogenic bacteria? It is bacteria that do not produce any infection all the time, right?
But they exist in our organism.
And they can exist in our organism without harming us.
So they are waiting for a moment.
They're waiting for a moment that either immunity will decrease, either they will get in the place they are not supposed to be. And in this case, if they are getting in the place they are not supposed to be, for example, wound, or anything else that could be associated, or injection, or I'm talking specifically about surgical wounds, in such case, in any way they will produce an infection. So from this point of view, it makes a little bit sense, you know? But in our common life, so if we can divide it, you know how, if we are talking about nosocomial infections, in this case we could call them strictly pathogenic bacteria, because in most cases they produce an infection. But we should understand that as long as I am inpatient, my immunity already is decreased. So it doesn't matter, am I in a hospital with infectious process, with infectious disease, or with a fracture, or with any other kind of trauma or surgery, whatever. My immunity already is fighting with something, because immunity fights not just against pathogens, not just against infections, but also against intrinsic, about any abnormality and any intrinsic damage. So this is why somehow we can agree to each other. I wouldn't argue with other doctors who would say they are strictly pathogenic, but if we are talking in terms of producing, non-producing infections in our common life, it would be also fair to call them conditionally pathogenic bacteria. What is good about them, I already told, not every time they will produce a disease, even if they are in our bodies. What is bad about them? They are highly resistant to the environmental factors. They're highly resistant to the environmental factors, to disinfectant substances, to antibiotics. So most of infections, multi-drug resistant infections, you will find in hospitals probably will be on first place staphylococcal infections, And on the second place, if we are talking about specific species, also streptococcal infections can be highly resistant for antibiotics and other environmental factors. If we are talking about strictly pathogenic bacteria, say Neisseria we've been talking about last week. Neisseria genus is making part of strictly pathogenic bacteria. Any time it gets in our body, it will produce a disease. So if Neisseria will stay in the environment for a long period, there are not too much chances it will survive in the environment. Because it will dry, it will die because of sunlight, because of UV lights, because of high or low temperature. So a little bit deviation of environmental factors, and most of strictly pathogenic bacteria will start dying in the environment. This is specifically why they are called strictly pathogenic bacteria. They show their activity just in our bodies. Now, what is also positive, they do not produce that often antibiotic resistance, strictly pathogenic bacteria. Now, if we are talking about Staphylococcus and Streptococcus, there are a lot of things that are in common, starting with morphology. It is shape, it is cell wall structure. Yes, it is what is in common. If we're talking about morphological differences, it is arrangement. You can see here, and you can remember that shape is the same, but arrangement. Staphylo means grapes. They're arranged in clusters. That means they are multiplying in any direction by any x. If we're talking about Streptococcus, they are dividing just on one x in chains. If they have similar cell wall structure, of course they will be stained in the same way. But still, this picture can be a little bit misunderstood because these two pictures are from two different sources. But basically, both of them are purple. Okay, and both of them are gram positive. Talking specifically about their morphology, also we can observe that both are non-motile, both are non-encapsulating. Meanwhile, it could happen sometimes for some pathogens to produce different extra structures. So some bacteria, especially highly resistant bacteria, sometimes, even if it is non-encapsulated, sometimes in uncomfortable environmental conditions are able to produce capsule. So normally it is non-encapsulated, but if they have some mutations, they could produce capsule for that specific period, and after that it can be removed. Again, difference between gram-positive, gram-negative bacteria, you can observe it in here. What is important about its physiological features? Even if both are both of them are aerobic bacteria, still sometimes they can show features of facultative anaerobes. It is also very important because you can see variety of their features that make them more accommodated to the environmental factors. What is specific about Streptococcus in this case? Very often, different species of Streptococcus are showing hemolytic features. You can remind that Streptococcus can produce different infections. Yes? It starts with our childhood. You remember which infection can be caused by same pathogen in our childhood? It is an infection that is common for children. Do you remember? Not too fast. Scarlet fever. Did you hear about it? Scarlet fever. Yes. Do you remember the mostly characteristic symptom of scarlet fever? This one. The tongue that looks like what? Strawberry. Yummy. It is characteristic specifically for children, for small children. So, what else can be characteristic for streptococcal infections? We already told. So, during we are observing this presentation, you can pay attention. The left side is for Staphylococcus. The right side is for Streptococcus. Okay. So logically, you can make difference. If we're talking about staphylococcal infections, very often they are causing purulent infections, especially skin infections, wound infections. Yes, we have Staphylococcus epidermidis that is present almost on everyone's skin. It is Staphylococcus aureus is present almost everywhere. If we are talking about Streptococcus, also they're causing pyogenic infections. And also we can talk about surgical wounds. For example, just to have a general imagination, I am making my research right now on Staphylococcus aureus, and I receive specimens of bacteria from the Republican Hospital. Statistically, at least one patient with staphylococcal infections every day is diagnosed. Yes. So I asked the lab, how much specimens, or how much strains of bacteria you can give me. And they told me about one a day. About one a day, we have a new specimen with Staphylococcus aureus. So not. Somebody would say not that much, but you can multiply it with the entire year, yes. And every year, over 300 patients they have staphylococcal infections just in Republican Hospital. So it is something. It is on the first place in the world as nosocomial strain. So it is nothing new. If we are talking specifically about nosocomial infections, it is very important to mention here incidence of nosocomial infections. So on the first place, if we are talking about wards, in which wards we have nosocomial infections or healthcare associated infections. On the first place will be burn ward. And statistically it will be, the range will be very wide. It can be from 30 up to 90% incidence. On what it will depend. If we are talking about burn ward, we have skin lesions. And as well as you should remember, skin is our first line barrier in this life. It protects against trauma, it protects against foreign bodies, it protects against infections. So it is our first line barrier. And as more damages of the skin or mucous membranes we have, there's more chances for infection we have. Now imagine that there is one patient that gets in the hospital with 1% skin lesions. In such case, chance for nosocomial infection, especially skin lesion, will be it could be about up to 30%. Do you think 1% is a lot or not? Can you imagine, or to what you can compare 1% of our skin? How much is it? It's 1 pound. So if you want to check it out, you can cover yourselves with your palm about 100 times, in order to cover the entire body. So it is about 1%. Is it a lot or not?
For me, it's a lot.
It is. It is. When you hear 1%, 1%, not that much. But when you compare it with 1 pound and you...
It's enough to make infection.
Absolutely enough to make an infection. That's right. Now imagine, just try to imagine when you can hear in breaking news that it was an accident or it was an incident with a fire, and some people got in hospital with 30% skin lesion, 30%. Before you knew this data, even 30% didn't sound that much. But now, try to cover yourself 30 times. And you will understand even 30 is too much. And what about people who got in hospital with 50, 60, 90% skin lesions? Too much, too much. Now, how big is the chance to get an infection in such cases? Almost 100%. Almost 100%. Such patients will need very good caring, very good antiseptic measures applying. Now, on the second place, we will have ICUs. On the second place, incidence of nosocomial infections, we will have intensive care units. Okay? Why specifically intensive care units? First of all, we don't forget the mostly common pathogens are conditionally pathogenic bacteria. Second, we don't forget any patient who gets in the hospital is instantly with reduced immunity. Next one, we don't forget that any patient who gets in the intensive care unit is the mostly critical patient. Yes? If I have a simple surgery, after this, without general anesthesia, after this surgery, I don't get in the intensive care unit. I'm getting in the ward, and I'm waiting for the further treatment and recovery. But if I've got a little bit more complicated surgery, and I'm getting in the intensive care unit after that for recovery, to make sure everything is good and I started recovering better, and after that I'm transferred in the ward. So, it is when we are talking about something usual. But intensive care unit serves also for extremely complicated patients. And it includes a lot of traumatic procedures. Injections, catheters, some small interventions, some small surgeries. It is laying patient, not every time unconscious. So this patient is not able to go to a bathroom simply. We need to apply urinary catheter, maybe sometimes diapers. So in such a framework, risk of infection will increase even more, right? Now, when we are talking about catheters, if it is peripheral catheter or central line catheter, it is a risk of CLABSI, central line catheter associated bloodstream infection, or cocci, that means catheter associated urinary tract infection, or surgical site infection, whatever. If the patient will need intubation, one more traumatic procedure. Not every time intubation passes very easy. When you apply intubation, it is a traumatic procedure, because if you need to do it, probably we have an obstacle here, right? Excuse me. So, it is a high chance to make a trauma of upper and middle respiratory tract, and here we also can get an infection. Plus, patient who is lying for a lot of times, it is a high chance for pulmonary edema, and in this case, chance for infection will increase, because in our respiratory system we also have some bacteria that normally doesn't damage. But if circulation is not good enough, in this case, chance of pneumonia, bacterial pneumonia, will increase. dramatically increase. Now, not every time you can apply intubation. In such case, tracheostomy is made. One extra gate for pathogens, one extra surgical site infection can appear. And what is different between ICU, where can be applied some surgeries, some minor surgery, and actual surgical ward? If we are talking about something of emergency, you don't have too much time to prepare patient for intervention, for any kind of invasive procedure. You just make a local aseptic measures and you start working, because some risks can be neglected in comparison with risks we try to reduce. Risk of mortality, right? So if we are talking about planified surgery, in this case, the patient will take a shower, will prepare him or herself. If it is a specific place that should be shaved, it will be shaved in patience, yes? So you prepare the surgical field by washing, and after that also by aseptic measures. But if it is an emergency, you just make some antiseptic measures or aseptic measures and you start working. The risk of infection will increase. Now on the next place we'll have dressing rooms. Dressing rooms. It is also very important. And this is what you should keep in mind, because I guess you already started making your practice in hospitals, right?
Yes, doctor, summer.
Last summer, and probably you had to do something in dressing rooms, maybe started making some injections or something like that. Or yes. So a lot of infections are happening or acquired in the dressing room. Why? Because you have a contact with a wound. And if you didn't prepare yourself good enough, what does it mean? We should keep in mind before and after each contact with a patient. You wash and disinfect your hands. Extremely important. Regardless wearing new gloves every time. Not talking about that, but all the time before and after having a contact with a patient, you wash and disinfect your hands. It's very important. Important for a few reasons. First one, it is safeness of everyone, you and patient. You never know what you can give to a patient. You never know what patient can give to you. Second, it is respect. It is respect. Moreover, it is very good to do it in front of patient. The patient is entering. You're saying, "Come on, please," and you're starting washing your hands. In this way, patient already knows
That he is safe.
that he's safe. Patient already knows you respect him and you want to give him the best medical service. And after that, patient feels better with you. And you're starting talking, maybe some manipulations you need to touch patient. And after that, if you need, yes? So after that, you maybe make some injections, or you work something with the wound. And here you also apply everything that is clean. Yes? So very often students starting learning practical medicine from these steps. And this is very important to avoid any harm, to avoid infecting patients. And on the last place, we'll have surgical wards. Why surgical wards on the last place? I already told before we make planified surgery, we prepare patient the best. So conditionally we can say that surgical ward is somehow sterile, or at least it should be. Normally, no windows opened. Yes, long time ago I've been witness of something like that. Summer, it's hot, I understand, but actually air conditioning should be provided in any, and air filtration in any surgical wards. But long time ago it wasn't possible in any hospital. So I've been witness of something like that. Summer, it's hot, surgery, doctors are working. Of course, you cannot work with a closed window because it is extremely hot and you will start sweating directly in the wound. It shouldn't be like that. They're opening the window and flies are flying in the ward. Yes, fortunately it was a long time ago, but it still happens in some places in this world. Can you imagine how will increase the risk in such case? And go and look for that fly after that to prove it wasn't you who infected the patient. Well, the surgical ward is to be sterile. That means all the surfaces are to be disinfected. Talking about walls, talking about floors, talking about surgical table and all the tools. And all the tools we are using are to be sterilized. So everything that enters in contact with ourselves is to be disinfected, but everything that enters in contact with patient and specifically with wound is to be sterile. It's very important. So if we respect all of these rules, the incidence of surgical wound infections will decrease. But if we do not respect, and one of rules says that masks should cover both mouth and nose. And fortunately, we had this pandemic to teach a lot of people to do that finally. But before I saw a lot of surgeons covering with a mask just nose. And on one side I can understand it. I can understand it because most of them are wearing glasses. And if you wear your glasses and you put the mask,
To block the vision.
it will make your glasses foggy and you see nothing. Still, there are some tips how to reduce this effect, how to prevent this. And if you really want, you will find one. For example, if you turn a little bit like this, the lower side of mask, all the steams will go down, not up. Or we have a lot of solutions. You can cover glasses and they will not get foggy. So also you can use it just if you want. But if you just care about your own comfort and you are not thinking about the fact you're probably carrier. One more thing, very important, making screening. Especially if you want to become a surgeon. Who wants to become a surgeon? Please check it out. If you want to become a surgeon, please check it out. If you are not carrier of Staphylococcus aureus in your nasal cavity, statistically over 50% of adult population are carriers. If statistically over 15%, that means much more, because not everybody is checking out. So it is very important, because if you will infect almost every patient of yours, your knowledge, your experience, nothing will be important if you infect each student of yours, each patient of yours. Okay. Now, how do we treat? Too fast, guys. We're finishing already. Please, dear chiefs, mention absent. Okay, these two guys. So, whenever we are talking about nosological forms of infections caused by Staphylococcus or Streptococcus, especially in the hospital, we should keep in mind that basically nosological form will depend not on pathogen. When we are talking about mandatory pathogenic bacteria, usually it has its own specific gate of entrance in our body. Simply, last week we've been talking about Neisseria genus, right? If we are talking about meningococcus, it has its specific way or its specific gate of entrance. It is nasal cavity, correct? When we are talking about Neisseria gonorrhea or gonococcus, it also has its specific gate of entrance. It is either genitalia, either other mucous membranes. It depends place of contact. So, in these cases, it is very clear the mostly specific gate of entrance. When we are talking about conditionally pathogenic bacteria, and especially about nosocomial infections, the gate can be different, and it will depend on disease, on affections, on way of treatment measures we apply to a patient, on each traumatic procedure we apply to a patient, because each traumatic procedure, even if it is benefic for a patient, it is extra gate for infection. So, especially on gate will depend nosological form. Either it is a respiratory tract infection, either it is bloodstream infection. If we apply some intubation or something, it is a higher chance of respiratory infection. If we apply bloodstream catheter or central line or peripheral line venous catheter, we have high chance for bloodstream infection. If we apply urinary tract catheter, we have urinary tract infections. If we have surgery, we can have surgical site infection. The pathogen can be absolutely the same or different. It doesn't matter. It matters the gate of entrance. And if you will look for a statistic of pathogens, which pathogens are mostly common for nosocomial infections, you will observe most of them are conditionally pathogenic bacteria. It's not just on first places can be Staphylococcal and Streptococcal infections, especially Staphylococcus, and specifically Staphylococcus aureus and Staphylococcus epidermidis. These two are extremely spreaded. And also you will see a lot of other other conditionally pathogenic bacteria, such as Pseudomonas aeruginosa, such as what else? At the moment you forget a lot of words. Well, you will observe most of them are conditionally pathogenic. You will observe a lot of them are gram-positive. So, how we treat? Lab investigation, that's clear, right?
We collect specimen.
Lab investigation. Specimen we collected depends on what?
Depend on the symptoms.
Very good. Specimen depends on symptoms. As well, we've been talking last time. It depends on symptoms. You are taking specimen from specific affected area, and we make cultivation. Usually, conditionally pathogenic flora is not too much capricious to culture media and conditions. You know, they can survive in almost any conditions. So, any common culture media you will apply will be good. But if we are talking specifically about streptococcal infections, we have three groups of Streptococcus, classification according to hemolytic features. Because Streptococcus is characteristic by hemolytic features. So we have three groups: alpha, beta, and gamma hemolysis. And mostly bad one or mostly severe one, you can even see here in this slide that beta is on the first place, alpha on the second, and gamma on the third. Streptococcus pyogenes, the most common one, is making part of beta hemolytic group. It is group A, beta hemolytic streptococcus. So that means as soon as it has a contact with our bloodstream, it will provide hemolysis. What is important about Staphylococcus specifically, if Streptococcus will provide hemolysis, Streptococcus usually is not that supposed to get antibiotic resistance. Streptococcus is not supposed to make resistance, usually. The species that are able to produce resistance are Streptococcus viridans. It is one of the mostly common nosocomial strains. But most of staphylococcal pathogens are producing antibiotic resistance. So especially for staphylococcal infection, it is extremely important to make checkup for resistance, because most of them will be resistant. And during your practice also, you will have a deal especially with methicillin-resistant Staphylococcus aureus. It is also a very important thing to know because methicillin resistance means it is not resistant only to methicillin. Moreover, methicillin is not a common antibiotic for treatment anymore. It is more common already for sensitivity checkups. Moreover, it is not necessary to use specifically methicillin for checkup in order to understand that it is methicillin-resistant antibiotic. Basically, we have one specific group of antibiotics that is called beta-lactamic antibiotics. Penicillin also is making part of that. So, in in its chemical structure, it has beta-lactamic circle or part. And Staphylococcus, methicillin-resistant Staphylococcus aureus, has a specific ability to produce an enzyme that is called beta-lactamase that is able to destroy beta-lactamic portion or particle of a chemical structure of beta-lactamic antibiotic. As a result of this action, the antibiotic becomes useless. Now we have a solution for that. We have antibiotics with clavulanic acid within. For example, as well as I remember, amoxicillin. So it contains also clavulanic acid, and this acid is able to block beta-lactamase. So for any action, we can find a contra-action. For such cases, this antibiotic will be useful. But the issue is that the beta-lactamic group is wide enough, is broad enough, and we have a lot of representatives of beta-lactamic antibiotics that are specifically indicated for gram-positive pathogens, especially for staphylococcal infections. So if we can find a staphylococcal infection, it is very important to make this checkup, and here you can see an example of checkup for resistance, and to choose the mostly useful antibiotic. And it is important, as well as we've been talking last week, to keep the treatment till the end, to not make abandon treatment, right? Because if we'll abandon the treatment, it is even higher chance to produce one more level of resistance. My favorite classification of antibiotic resistance is MDR, XDR, PDR. That means MDR is multi-drug resistance, and multi means more than one. Very often when you can hear multi-drug resistance, you are thinking that it is a lot. No, more than one. So basically, if you have resistance to at least one antibiotic, it is already multi-drug resistance, because this antibiotic is making part of a specific group of antibiotics. And it is also already multi-drug resistance. We have XDR, extensively drug resistance. XDR means we have just one or two susceptible antibiotics. The rest of them are the pathogen is resistant. So just one or two antibiotics are still useful. And we have PDR, pan-drug resistance. What means this root pan? Totally, or globally, or universally. In this case, totally. That means it is resistant to any antibiotic, any existing antibiotic. So, what is the solution? Good question. First of all, the best solution is listening the lecture and not doing something else during the lecture. Because I understand that you observed from the last week, you can listen it again on YouTube, yes? But those who are not listening for the first time, either less chance you will listen for the second and third time. Statistic. Second, it is very important to not make same mistakes, because everybody can make mistake, but if you repeat the mistake, if you make a mistake, that means you are doing something. If you repeat the mistake, it means you are doing the same without thinking. If you repeat your mistake at least twice, that means you are not thinking. You are just doing the same thing again and again. So it is impossible to get PDR instantly. We have stages. In the beginning, the pathogen will be susceptible to any antibiotic. If we make one mistake once, it could happen. It can be my mistake as a doctor. It can be his or her mistake as a patient. It can happen. But next time you discover this issue, you will observe it is already MDR. So here, it is very important to explain it to patient and maybe to doctor sometimes. And to say, you know, it is a crucial moment when either we will move to XDR and after that to PDR, either we will finally kill this pathogen and we will stop spreading multi-drug resistant strain of bacteria. It is very important. But if we do not care about that, we'll have it again and again, and finally there is a solution still. Less solutions because antibiotics are mostly useful drugs for bacteria, but not only ones. It is very important to keep in mind because except antibiotics, we also have other drugs. Can you give me an example of antibacterial drugs that are not antibiotics? Any examples? Bacteriophages, for example. A long time ago, bacteriophages used to be very common drugs against bacterial infections. Now, not too much. Maybe soon we will come back to them because of wide bacterial resistance. So bacteriophages, what is awesome about them? They are multiplying themselves. As more bacteria we have, as more bacteriophages we have. First. Second, they cannot attack us. They can attack just bacteria. So that's enough, just like a teaspoon of bacteriophages to administrate. And they will get in your body and they will multiply until that amount, specifically that amount of bacteria you have in your body. That's it. After that, they are killing the bacteria from the within. Huh?
It's not really great.
I have no idea. I wasn't there. I was a child. But I say maybe soon enough we'll come back to this way of treatment. And also any other ways are developing right now. And one more solution, everything that is PDR today can become XDR tomorrow. A new generation of antibiotic appears and it moves back to XDR. We're using this chance if it happens. It should be a miracle that first of all PDR cases are not that spread not that often. Second, we need to get to this new drug in that very moment. So if these two rare events are happening, it could also happen that PDR will come back to XDR, and in this case you apply the treatment. It could happen. But basically, please don't lead your patient till this condition, because otherwise everything is in vain. Okay? So, as a lab investigation, we are using bacteriological method. That means we cultivate bacteria. We can use PCR, we can use Vitek, especially for staphylococcal infection. Extremely good device, extremely good investigation that shows all features, that shows species, that shows even serovariants, and instantly at the same time resistance to antibiotics. So some investigations that could last for a few days will last from a few hours up to one working day. It's very important. That's awesome. We have such techniques and such devices. And of course, before we apply treatment, first one is antibiotical treatment. Second one, before we apply antibiotical treatment, is very important to check out resistance. Okay. And except antibiotical treatment, we have surgical treatment. Surgical treatment of infection when we have a purulent infection. We have a big accumulation of pus. In this case, antibiotics will be useless unless you are making the cleaning of the wound. You remove all the pus. You help the wound to recover, and at the same time you apply antibiotics to remove just rests of bacteria. Also, we can make some drains. That means you introduce saline solution in the cavity that is infected. Very often this method is applied for abdominal cavities or something like that.
I have seen it after lumbar surgery.
Yes, but it is drain. It is drain that helps to clean the wound. So antibiotical treatment is the first line treatment, but we need to give a little bit more support to body to recover as soon as it possible. Any questions?